Morning, morning everyone. Hope you are well. Right, let's just make sure everything's working. Looks as if people are here, which is good. If you want to pop some messages in, oh, people already have. Good morning, Becky. Hi, Ave. No probs. Cool. Welcome for the first bit. So we are, we're moving up the body a little bit now. So we're going on to the knee. And hey, Stevie, good to see you there. Busy week this week. We've got Therapy Expo this week. So if you're in and around Birmingham and you're a bit bored, then come along to Therapy Expo at the NEC. And I found, where is it? Bear me a sec. Oh, here it is. Found this. Oh, it's backwards. You get the idea. So it used to be in Manchester 10 years ago, and that was the first talk I did. I think it was the very first one, actually. I think that was, so they let anybody on the bill in those days. And so I have been speaking at Therapy Expo now for 10 years, which is just mental. Good morning, Jane. Morning. Yeah, see you there. Good. Oh, good. Good. Oh, I'm glad. It'd be good to see you, mate. Very good to see you. You're going to make lots of people jealous now. All those people that are able to make it. You're going to get some FOMO going on. Cool. So we finished off the foot and ankle, and I think it took about 7 or 8 weeks. So there's a lot of footage there. There's probably there will be like 7 hours worth of delving into the foot and ankle. So hopefully you've got everything you need if you are doing revision for exams. Morning, Tris, another Therapy Expo attendee. We'll see you there on Wednesday. So we're moving up to the knee. And we're also going to include a little bit of what Eleanor wanted to do, which was, I think it was Eleanor, wanted to do some stuff on the lymphatics. I was going to do it for today, and then looked at it and I was like, this is going to take me a few weeks to prep. So we're going with just bones and joints of the knee, which I don't need any time to prep, so that's good. And when we get to the vessels, when we start looking at the blood vessels, then I'll start. I'll prep a specific session on the lymphatic system, and I will obviously include the lymphatics of the knee, but also have a look wider what the lymphatic system does for the whole body, and how it all kind of links in together. So so that's the plan. Just needed a bit more time to prep once I looked at it. I want to do it justice. So good morning, Maureen. Good to see you there. A new joiner with us. Welcome. So that's the plan for that. And we've never really covered lymphatics before. And the reason why we haven't is because you can't see it on cadavers. So because when somebody dies, the lymphatic system just dries up. So and especially if they're set with formaldehyde. So people didn't think it existed, and they just because obviously they could only work on dead people. They couldn't really do scans back in the old days. So the lymphatic system was kind of this like, ooh, there's something going on, but nobody really knew. And then obviously as we can track things and we know more about the immune system, we realise that it is definitely a thing. And so we'll cover that, and also because we've got quite a few people in the group that are from either an exercise or a therapy background, we'll have a look at the implications of the or the functions of the lymphatic system on fitness, and what fitness does for it, what movement does for it, and also how therapy may or may not affect it. So we'll have a look at the evidence for that as well. Cool. So let's just get my PowerPoint there. So we've got bones and bony landmarks of the knee. So that's what we're focusing on today. So this is, apologies if you have some anatomy knowledge around kind of basics of the bones and joints of the knee, because we're going to teach you to suck eggs. But as you know, as we go through the weeks, we start layering on more and more information, and then you start covering stuff that you don't really know so well. But the bones and the joints are really important for adding on the ligaments and the muscles, especially the muscle insertions and ligamentous attachments later on down the line, because there are some key areas where we need to know the bony anatomy, and then that makes the ligamentous and the muscular anatomy make sense. Okay, so it's always good to recap. So maybe going over old ground, and apologies in advance, but there's nothing wrong with a bit of a recap, is there? I think it's always good. And even for me, I've said this before, when I'm prepping for these, there are things within the sessions where I'm like, oh, I'd forgotten about that, because unless you're doing it time and time again, or it's an area that you have a specific interest in, you only remember the bits that you use more frequently. So yeah, I think it's good for everybody to have a bit of a recap. Right, let's get going. Okay, so let me just get rid of that. So yeah, the knee, anatomical region made up of these areas. So we have the femur. Just grab the model here. I'm just going to go to the screen. So these are the models that I recommend. They are pretty pricey, unfortunately. Just have a look at the make. I've got the rest of him over here. I think it's 3B scientific or something like that. But the good thing is with these is they've got these little blue and red markers on. So these are really good because they are the attachment points of either muscles or ligaments, whatever. And I don't know whether you can see on there. There we go. Let it zoom in. There you go. Can you see the little numbers? So each area is numbered, and then that corresponds with a booklet that you get, or they do it online now. You just search up the number, and then it will tell you which muscle is which. So these are really cool because then you can match up the numbers. You can attach things like TheraBand from the red bit to the blue bit, and then you can move the limb and you can see what happens to the tissue where it's attached from and to. Yeah, they are pretty expensive, but I've bought some cheapy stuff in the past, and they just fall apart. Especially the hanging skeletons. Obviously, that's useful for me with teaching, but also it's good for showing patients as well. So you can show patients the anatomy as well when you're trying to explain stuff. So these will last you a lifetime. Yeah, these ones are really, really robust. So well, you'd hope they would last for a while for 425 quid. So obviously we're going to be talking about this bit. So the knee, and it's made up of the femur, which is your thigh bone. So this one just here. We're going to talk about these bits in a bit. So which bit does what, because all of these little lumps and bumps have got a specific name as well. Then you've got your shin bone. We've been looking at that end previously. So we've been looking down at the ankle and the foot. So we're going to be moving up here now into the knee. And also this bone here, the fibula. So even though it doesn't join onto the femur, it has a role to play in the movement of the knee because of the attachments of the muscles that are there. We're obviously with dry bones, there's no connective tissue, so there'll be bits and bobs on here where we've got cushioning structures. We've also got a capsule around the knee, which we'll have a look at. I've just noticed. Can you guess what I was doing on the weekend? I haven't washed my hands properly. Yeah, got white paint everywhere. So yeah, we've got structures in the knee that help to cushion, but also guide the movement of the knee as well. And I think one thing that is really interesting that's coming out in the literature more and more now, especially with changes in the knee, So you have probably heard of osteoarthritis and osteoarthritic changes, and it's seen as a kind of wear and tear type issue. And you get a scan done, and you have a look at the knee, and you go, "Oh, there's a lot of wear and tear there." And if you speak to an anatomist, then and they show you those models in the clinic, they'll go, "Oh yeah, that would have been really painful," and that's not the case. Okay, so there's lots of evidence now to show that people can have changes in the knee, really horrendous looking things, but no pain whatsoever. Okay, so what we're realizing is that the pain is more closely related to strength issues with the knee, and maybe there's a correlation there. So if it's painful, then you're not as strong. But working on strengthening the knee and the scaffolding around the knee helps with knee pain, which is good, but the structure doesn't change. Okay, which is interesting. So people thinking that they need operations when they might not need it. The other thing that is a correlation with pain is inflammation. And there are lots of reasons why you may have inflammation in the joints, and it's not just to do with changes in the joint. It can be to do with your lifestyle and hormonal imbalances and things like that. So we're realizing that it's not just a structural problem, that may be part of the problem. But just because somebody has like creaky knees, or they've had an MRI or an X-ray and it showed degenerative changes, that doesn't mean that they're going to have symptoms. Okay, so yeah, so that's useful information to know. Okay, so what else have we got? Yeah, so femur, thigh bone, tibia, which is your shin bone, fibula, which is this one on the outside here. Yeah, and you should be able to feel that. So if you have a feel of the front of your knee, and then move to the side. So this is a left leg, okay, that I've got here. You move to the side, and you should be able to feel that bony lump on the outside, just in there. Have a bit of a dig in. Sometimes it's quite superficial. It can be quite tender. And when we were looking at the foot and ankle, we were looking around this area because this is where the nerves come through. Okay, so and we'll add those in as we go. So it wraps around that fibula head. There's a nerve that wraps around there. And have a look back at the ankle and foot videos for that. I'm not going to go into that right now. We've also got muscles that attach onto here. There's ligaments that attach onto here, and that both act on the foot and act on the knee. Okay, so there's a lot of stuff going on around this fib head, and it can be quite, yeah, like I say, it can be quite sore. The other thing is your patella. Okay, so which is your kneecap, patella just there. So that's this bone just here. Okay, and some of the pathology that you can get here, some of the things that may change, is the undersurface of the patella. You can also get changes to the tendon, so where the tendon attaches. But well, again, we'll talk about this as we move into the muscles a little bit more. But the patella sits in the tendon. Okay, so it's not just like the tendon attaches here and then comes out here. It surrounds the whole thing. So you can have really, really sore areas all over the patella tendon, like actually on the kneecap, and it can be a what we call a tendinopathy. Classically, it's described as being here, this pointy bit of the patella, but it doesn't necessarily need to be the case. And then the tendon then attaches onto this bit here, right there, so, and you should be able to feel that as well. So if you feel down the front of your kneecap, go down onto the shin, and there is a bony lump on the front of your shin. So if you rub your kind of finger backwards and forwards like that and side to side, you should be able to feel quite a distinctive lump. And that's called your tibial tuberosity. And that area there is where all of the thigh muscles on the front attach into there. Okay. Yeah, it's really frustrating. It's one of those things where it's kind of as things evolve, but then if you don't keep up with the literature, then yeah, you're just perpetuating the old myths, unfortunately. And I think some of the ways around that, I learnt this from a chap called Greg Lehman. He was really good at explaining how to explain things, because it's quite challenging when, I'm just a lowly sports therapist or massage therapist or fitness instructor or whatever, and then you've got a consultant saying all these things, or a doctor, a GP, or whatever, and actually you've read more than they have about this particular condition. And who's the client going to believe? Of course, they're going to believe the GP or the consultant. So he said, what you can do is say, look, these guys are really busy, and this is an area that I'm really interested in. So I've been doing a lot of reading, and I'm really up to date with the literature. And sometimes those guys, they just don't get the chance to read up about everything because they're covering so many areas. And it's a bit of a backhanded compliment, I guess. They're very good at everything, but I've really read into this, and that's how he kind of explained to try to help clients realize that actually you're the one that's up to date. Okay, so without trying to put the other people down. Penny, welcome, no problem. Right then, so those are your four main anatomical regions of the knee, and then we've got different joints. Okay, so just move me out of the way there. So three main joints in the knee, and you might have just thought there was one, but you might have just thought it's that kind of like that hinge joint in the middle, the bit that does that, but it's not, and it doesn't just do that. It also, there's a bit of rotation in there as well, and we'll talk about that as we go through. So we have these joints. So we've got the TF joint, which is the tibiofemoral. So that's your classic kind of knee joint. Okay, you need to know the bones so that you can work out what everything else means. Okay, so that's why we start there. So we've got the tibia and we've got the femur, and where those two, I don't know why I'm doing that with my hands when I've got this. So tibia and femur, and where the two join together, that is your tibiofemoral joint. Okay, the classic kind of, if you were to think of a knee, that would be a classic knee joint. So that's this bit in here. Okay, then you've got your patellofemoral joint. So there's your patella, and there's your femur. So the join in between the two is your patellofemoral joint. So I don't know whether you can see. Can you see there? Can you see the shape of the patella? Yeah. So it's not just flat. It's not like a skimming stone. It's there's these convex areas where they come in the middle. Can you see that there? Yeah. And can you see the groove as well for the just there? So we've got this roundy lump here, roundy lump there, and then there's a groove here. So this bit's concave, so it's caving in, and then this bit's convex. So there's a little bit like sticky out bit there. Now you can have all sorts of different shapes of the patella, and the shape of it will determine the kind of potential problems that you might have. So you can have a very small patella, and if you do, then it's way more likely to dislocate. Okay, you can have one that is squinted, so it's kind of rotated a little bit. You can have a kind of flattened undersurface. You can have a roughened undersurface. These bits can be all roughened. These bits can be different shapes. So there's loads of different variations with the knee, and sometimes the shape of the joint determines the potential for injury. Okay, so one of the things they'll do, especially if you're a young kid and you have frequent dislocations, they will look at the shape of the patella, but they'll also check out the connective tissue, because then obviously all of the soft tissue structures keep that in place as well. Okay, and so there's various different things where it's just unlucky. Yeah, it is the way it is, and you can do some things to help to minimize the risk of, especially with a dislocation, but sometimes you just have to change the activity that you want to do. Okay, so which is really unfortunate, but it's part of giving advice, isn't it? You say if you keep doing this and you've got these kind of structural differences, then this is more likely to happen. All right, so yeah, it's not just always shaped like this. There are lots of variations. So that's your patellofemoral joint, and then we've got the superior tibiofibular joint. So superior means above, tibia, fibula, fibula. Okay, so in between your tibia and fibula, there is a joint in there. So that little joint in there, and that bone moves. Okay, so it will move anteriorly and posteriorly. So that means it will go forward and it will go backwards. So if that bit moves at the top, this bit will also move. Okay, it doesn't move a lot, but it kind of seesaws. So if the superior joint goes backwards, the inferior joint will come forwards, and vice versa. And that will happen. So when you go into dorsiflexion with your ankle, so the foot comes up, then you'll get movement at the fib joint, but at the inferior portion. Okay, so as you come up there, it will move your fibula slightly posteriorly to create room for your ankle to come up. So that means that this one will come forward slightly. So sometimes ankle restrictions, ankle mobility can be affected by this bone up here, by the knee. So if you've tried everything around the ankle and you're thinking, blooming heck, like it doesn't seem to be anything's helping, it may just be that the ankle's a problem, and there's changes in the ankle, or it may be that they've got a restricted fibula, and you can literally grab hold of it and give it a wiggle, and it should move. Okay, and if it's really sore, then it may be the soft tissue structures coming into there that's causing that restriction. Okay, so something to look at here if there's a problem distally. Okay, so that can be an issue. Cool. Then we've got so we've got the tibiofemoral joint, so your classic knee joint, and this has got a number of different ligaments that attach to it between the two bones to maintain the stability of the knee. Okay, so that it's really important for passive stability, so where you don't have to use your muscles. So to save energy, when you used to do that thing at school where people are queuing in the line for dinner and or for lunch, and you've got your legs locked out, and then someone comes up behind you and just pushes the back of the knee, and your legs kind of go, and it's because you're hanging on your ligaments. Okay, so which is an energy saving thing to do. So when you're in that position, you've got maximum congruency of the joint, so they're nice and tight. The ligaments are wound up, so then the muscles can relax. And that's why you only need a slight little nudge at the back of the knee and your knee goes, and then the muscles kick in and stop you from falling. Okay. Yeah, exactly. Yeah. So it can have a knock-on effect, because if you can't dorsiflex the ankle, then you'll change the way that you squat. And again, it could be a functional issue, so something like that, or it may be a structural one where the ankle just doesn't go in that position. Okay, but there are various tests that you can do to test whether it's ankle or more functional. Yeah, that's good. Yeah. Cool. So yeah, we've got these four main ligaments. Anterior cruciate ligament, we're going to talk about those next week a bit more. Posterior cruciate, medial and lateral collateral ligaments. And we've had collateral ligaments elsewhere in the body as well. You've got them in your fingers, you've got them in your elbows, you've obviously got them in your knees, you've got them also on your toes. What they do is when a joint does that, you've got these ligaments either side of the joint to stop it going sideways, to stop it going that way. Well, obviously it doesn't go because my ligaments are okay. But if you injure the ligaments on the side, then you'll get bendy joints. So if you did that with the knee, so the collateral ligaments for the knee come down either side here and here, and they stop your knee going in and out like that. Okay, so they maintain that stability in what we call the frontal plane, which is the side to side plane of the body. So I mean that the knee can be an issue as well as an ankle. Yes, yeah, absolutely, yeah. It's not. It's one of those things where it's probably not the first thing I'd check if someone's coming in with an ankle problem. I'd want to get to the bottom of the ankle issue and figure out exactly what it was. But if things weren't resolving, then start to look a little bit further afield and the potential movement changes that are happening above that may be overloading those structures underneath. So yeah, like I say, it's Mike James explains it really nicely. He said if you've got a big jar of stones, he said you want to sort out the big rocks first. Okay, so you want to get those big stones in first. Something like that would be one of the smaller ones, where once I've sorted everything else out and had a look at all those other things, then I'll start to have a look at those. Okay, so a potential issue. Cool. Right, let's have a look at some videos. Hopefully, here we go. Cool. So this first one. So this is your femur. So this is from, if you've not seen these before, this is from Ackland, Acland. They used to do VHS back in the days. Then they switched to DVD, and now it's all online. So if you want to subscribe to them, just search up Ackland. I've got some brilliant video. Well, it's all these basically, but I've edited them and put some stuff in as well. So this is your femur. Let's just get going here. Here we go. So we can see, just pause that there. Why is that not working? Just get rid of that one. Bear with me a sec. Weird. Let's see if that one works. No, it's not letting me control it on the screen. That's weird. Okay, so let's have a look. So these are the things that this is what we're looking at before. So this is the femoral shaft, and then these bits here, these lumpy bits, these are called condyles. Okay, condyle means a knuckle, and you've got a big knuckle here and here, and then can you see the groove in the middle? So this is that concave bit that the patella sits in, and it's this area here. All of this in a real person, someone who's alive, would be covered in cartilage. Okay, so it'd be nice and glistening, lovely bit of cartilage. And if apologies if you're vegan, vegetarian, I'm going to talk about chicken. But if you have a look at a chicken thigh and open up the joint, you can see the glistening white surface. And that's cartilage. Okay, and it's exactly the same in us as well. So it covers all of this area here, and the cartilage will be nice and smooth. Okay, or should be nice and smooth. And then the patella sits on top of that, and the undersurface of the patella is also covered in cartilage and is also nice and smooth. Okay, so they should go together quite nicely. Is Ackland, Acland. I think that's the lonely chap you're talking about, and not someone in the group. So that's your medial condyle. Okay, so medial means towards the midline, so towards the middle, and then lateral towards the outside. So this is the outside condyle, and you'll notice that this one is bigger. Okay, and that's going to play a role later on when we look at the function of the knee, okay, and how it all works and how it moves. Okay, let's just play that a little bit more. Okay, yeah, so we've also got, so intercondylar means in between the condyles, and there's an intercondylar notch, so like a little indent, okay, and that's important for later when we start looking at the ligaments. Okay, so I'll just put that there. Good. I thought you meant Ackland. There we go. So that's your femoral condyles, and then what we've got on top of those. So if we have a look here, let's see if I can get a right angle to see. Can you see that? Get my fingers on that bony lump there. So this is the condyle bit, and then that bit there is like a little raised lump, and that's called an epicondyle. Epi means upon. Yeah, so we've got condyle, which is the main knuckle, and then epicondyle means upon the knuckle. And there's one there. In fact, this one's that you'll see the epicondyles in a minute. This one is a supracondyle. So if I show you here, yeah, can you see that little lump there? Yeah, so that would be an epicondyle, It's a little bit. There's loads of different names for lumps. They all mean the same thing. So we've got trochanter, tubercles, condyles, epicondyles. They all mean like bony, lumpy bits. Okay, so we've got a bony, lumpy bit there, and then can you see? I don't know whether you can see it very well, but it's like a kind of ridge here. I wonder if you can see it on that one better. No, not really. So yeah, we've got this ridge area here, and that is because it's above the condyle. It's superior to the condyle, so it's supracondylar. Okay, so this area here, you can just about make it out there. It's a raised kind of ridge area. That is a supracondylar line. And again, that area will become important later when we start to look at the muscles, okay, and where the muscles attach. So supra means superior, medial means towards the midline. Okay, so this is on the inside of your thigh. And there are your adductor muscles, so your inner thigh muscles that come down here, and that's one of the reasons why we've got that ridge. Okay, so we'll have a look at those as we go through. So condyle there's your lateral supracondylar line. So lateral means to the outside, and that's a raised area there as well. And then all the way back round to the beginning. I think that's it for that one. Yeah, cool. Okay, so that's your femur. And some bony lumps on the femur that will help us out a little bit later on. And then this one is your proximal. So again, we'll go through the terminology as we go. So proximal means closer to the middle of the body. Distal means furthest away. So if you've got a distal and distance, proximal, approximate. Okay, so if you've got a proximal part of a bone, it's the bone that's nearest to your trunk. If you've got a distal part of the bone, it's the bit of the bone that's furthest away. Okay, so the distal part of the femur would be down here. The proximal part of the femur would be up here near the hip. Okay, and we use those terms to help us work out where problems are. Okay, so if you need to write notes about where a particular issue is, you would use proximal and distal, or anterior, posterior. Okay, so then we can be quite accurate with where we're talking about. So this bit we've just had a look at already on the model and on the pictures. So this is your fibular head, so the fibular bone on the outside. This is the tibia, so the shin bone, and you can see it widens at the top there. Okay, so it creates a bit of a platform for the femur to sit on. And then there's obviously this is dry bone, so you can't see it, but there are structures in between to help cushion and guide the knee movements. And there's the joint line just there. Can you see it's kind of like a slanty angle? And that's the one that I said if you grab hold of it and you can wiggle it backwards and forwards, and you'll only get a couple of millimeters movement, but it should move. And if you move the top bit, it's going to move the bottom bit. Okay, so they work, they both work together. Okay, cool. So that's your fibular head. There's your tibia. There's the fibula. Your tibiofemoral joint is the joint between your tibia and your femur. Okay, so that's your kind of classic knee joint. And then as we spin it around, you'll be able to see the joint here. So this joint, oh, that's a really annoying thing because I can't control the movement of it. Let me just see if I can get rid of some of those. Yeah, so that joint moves with the ankle, okay, which is what we were talking about before. So if the fibular head moves forward, then proximally, then distally it will move backwards, okay. And if if it's the other way, then it will happen the other way. Usually with the fibular head, if anything, it gets stuck backwards, and the reason for that is because your hamstrings attach into there, and the hamstrings will pull on that fibular head and pull it back. So then it can get stuck in that position, which then maintains a forward position of the distal fibula, and then that can potentially restrict ankle movements. It depends on how sensitive you are to that change. Quite often you'll be absolutely fine. Right, let's just pause that one. Get rid of that. Okay, so let's have a look. So these are the tibial condyles. Oh, this is working properly, this one. That's good. Good. Okay, so we've got remember the knuckles at the top? So the femoral condyles were femoral knuckles, and then we had supracondylar ridges, so superior to the condyles. And then on the condyles, so on those knuckles, there were another little lumpy bits, which were epicondyles. These exactly the same, but instead of in the femur, now we're on the tibia. So it's this bit here. So where it goes wide, and you've got that kind of shape there and there, those are your tibial condyles. And we have a medial, so on towards the midline, and we have a lateral towards the outside. Okay, so it's you'll notice the terminology is the same as we go. And then this bit here, this is an interesting bit. Let me just pause that there. So this is the articular surface. Articular, or an articulation, means a join. So this is where the femur joins with the tibia. They don't obviously stick together because they have to move. They're resting on each other, and then there are structures all around it to help move the joint and then help to protect and lubricate the joint. Okay, but this area here and these kind of flat surfaces, these are where something called the meniscus attached to. Okay, and you may have heard of meniscal injuries, meniscal tears. The meniscus sit on here, and they are stuck to it, but not fully. Okay, so they are movable, and you'll see that when we have a look at the connective tissue. But they'll glide and slide with movement. Okay, and that's and they need to, because if they were stuck and you landed and then twisted to change direction, and they were stuck solid to your tibia, you would just tear them apart like opening up a jar. Okay, because they have to be slightly movable, so there's a bit of give as we put load through them and then rotate. That is the way they get injured, by loading and rotating. But if they were solid, they would just get injured all the time. Okay, so there is a bit of mobility there to allow that movement to occur. Yeah, so these are the joining surfaces, the articular surfaces, and then on there, as we'll have a look next week, you'll see the meniscus. And then in between, can you see these raised areas here? Look at that there. Yeah. So see all of that stuff there that's raised up. So in the femur, there was that intercondylar notch. Yeah. And it's to make a gap for the bit on the tibia. And that's where your cruciate ligaments will attach to in here. Okay, one at the front and one at the back. And then they then go up and attach onto your femur. And again, we'll cover those in the next couple of weeks. But that's where your cruciate ligaments attach to. And because of where they are, what they do is they stop. So then remember, the ones on the side, they stop your knees doing that, going side to side. Yeah. The ones in the middle stop your knees sliding backwards and forwards. Okay, so if those weren't there, or there was an injury to the cruciate ligaments, then the tibia would just slide forwards or backwards depending on which ones have been injured. All right, so preventing movement side to side and forward and back, that's what your ligaments do. Okay, okay, just play that again, hopefully. Yeah, so that is called the interarticular area in this particular video, because it's in between the articular surfaces. So we've got an articular surface here, one here, and this is the raised ridge in between. And the reason why we get these ridges is because of life. Okay, so when you use your body and the muscles pull on the attachments and the ligaments pull on the attachments where they insert onto, they create forces through the surface of the bone, and the way the body adapts to those forces is by laying down more bone. So that's why we've got these bony lumps, and if you've heard me talk before, you'll hear me talk about that again and again. So some people will have bigger bony lumps than others. Okay, aren't they lucky? So we've got if you use your muscles more, then you'll have a bigger bony lump. Okay, you'll notice that right-footed people usually have a bigger left tibial tuberosity. And the reason for that is because when you kick a football, or when you go upstairs or whatever, when you jump and you're right-handed, believe it or not, you use your left leg to jump. You use your left leg to stabilize yourself as you're kicking a ball. Okay, so if you're a right-handed bowler in cricket, it's your left leg that is the lead leg. And it's quite surprising because you think, oh, I'm right-footed, so you'd expect the muscle pull on the right side to be more, but actually it's on the left. And if you have a feel on your knees, you might feel a difference between this one on one side compared to the other, and it's because of how you've developed your body over time. If you stopped doing a certain activity, it would take about a year, and then the bones would equalize. Okay, so if you did nothing, then everything will go back to the way it was, or to equal. So here you've got this is the tibial tuberosity. This is the bit we were just talking about. Just check time. Sometimes it's called the tibial tubercle, means the same thing. And then there's the angle of the joint there for the fibula, and there it is slotting in. And just go back a bit there. Okay, so there's the angle of the joint, and then there it is there. So you can see why it wiggles, yeah, because it's not kind of blocked by anything. It's stuck on the side at a bit of an angle, so it can glide backwards and forwards. So it's designed to move. Yeah, it's not supposed to just be stuck. Yep. Yeah, right or left-handed. Yeah, definitely. Yeah, you get an idea about how their body moves based on their handedness. Yeah, if they're ambidextrous, then all your theories go out the window. This bit here, we were looking at this a lot in the ankle because this is the interosseous area. So osseous means bone. Interosseous is in between the bone. Yeah, and there is a piece of connective tissue in there that separates the front from the back. And if you have compartment syndrome, then that can cause some problems. So we talked about that a lot in the ankle, so you can have a look back over those videos. But that is your tibia and your tibial tuberosity just there. What happens for it to equalize? Basically, because you don't pull on it, the osteoclast activity, so those cells that start to clear bone away, they start to override the osteoblast cells, which are building cells. So because you don't need much building, the clasts will just clear the bony lump away. Yeah, so you'll find it a lot with people who've been injured for say they've been in plaster for a while. Their bones will feel different. It's or if they've been they've been out, if you have an ACL injury, you're out of action pretty much for 9 months. So you will have changes to the physical structure of your bones. So it's not just the muscles and the ligaments that you need to rehab. You also need to think about the problems because you've not been able to weight bear. So the bones will start to change as well. Okay, so it's just something to add to the mix. And then the last thing is your patella. Okay, so this is the weird thing with the patella, is the base is at the top and the apex is at the bottom. Okay, classic. Why they didn't? I can see why they did it, because it looks like an apex, doesn't it? So it looks like a pointy bit. So the apex is here and the base is here. When we start to add the connective tissue on, this bone is what we call a sesamoid bone. You've got sesamoid bones in your thumb. You've also got them in your big toe, and you've got them here. And they are in areas where there is high forces that are needed. Okay, so for you to be able to grip and hold your body weight like hanging off a bar or something, the sesamoid bones help the muscles that pass through the sesamoid bones increase their efficiency and their force. So the big toe is really important for propulsion and for running and walking. The thumb is really important for grip, and obviously the knee is important for extension of the leg. So these bones help to maximize force from the muscles that they sit in. Okay? and this your patella sits in your quads, okay, which are muscles on the front of your thigh, and we'll have a look at what makes up the quads as we go through. So apex and base, top and bottom, and then there's your condyles. I'll just go back there, just pause that there. There we go. Okay, so there's your lateral condyle, and we know that's the lateral one because that is your fibula, and that's on the outside of your leg. Okay, so this has to be the lateral condyle. That would be the lateral condyle of the tibia, and then there's your fibula head with that slanty joint that we were looking at before. So the quadriceps encase the patella, and then they attach down here, which is your tibial tuberosity, which we were talking about before. So that's the bony lump that often overdevelops. And you can get something called Osgood-Schlatter's disease as well. It's not really a disease, it's an overuse type injury. This is the if you've not heard of that, then you can Google that. It's Osgood, Osgood, and then if you just put that in, it should come up with Osgood-Schlatter's. Schlatter's is Schlatter's. Okay, so this looks like a really good kneecap, to be honest. This is the undersurface of this person's patella, and I don't know whether you just caught it there in the light, but can you see the just there? Yeah, so there's grooves for the condyles either side, and then there's this convex area in the middle where it's slightly raised so it can sit in the grooves of the femur. And then here we go. Oh, I'm glad this video is in. So this is what the kneecap does. This is what sesamoid bones do. So what they've done, obviously, very rudimental knee. So we've got an elastic band which is attached down here on the tibia. Okay, you've got someone pulling the elastic band at the top, which is supposed to represent your quad muscles being pulled. This one doesn't have a kneecap. This one does, and this one still moves. Okay, but look at the difference in force that is applied. Okay, so that one on the right there has been pulled maximally, and it still wiggles the bottom of the leg a little bit, but not much. Okay, but then look at that. With the kneecap in place, you get leverage over that joint, which improves the efficiency of those muscles, so then they don't have to work as hard to produce force. Okay, so that is what your kneecap does. It helps your muscles produce force and extend, especially in this case, and extend the knee. Okay. Good question. Seeing as patella is encased in the patella tendon, maltracking patella, myth or legit? A bit of both. It is if you have a structural change to the patella, so you have a high patella, a low patella, or it's very small, then it can maltrack really, really easily. If there's nothing like that going on, it's less likely to be an issue. Okay, so it's not, again, it's not something that I would worry about too much. Some people feel that they feel better with strapping around the knee, and if it's dislocating, then that's a different issue. If it's like maltracking, you can change maltracking really, really quickly. So I think it's more of a neurological thing than it is a structural one. Okay, so there is some measure. One of my colleagues, when I used to work at the university, he did his whole dissertation on maltracking patellas and measuring them and all that kind of stuff. And really, it's unless they were dislocating, it didn't really make that much of a difference. So bit of myth, a bit legit. It depends. Yeah, sorry, it's one of those. Cool, brilliant. Run over a bit. Sorry about that. Warbling on. Getting my voice ready for Therapy Expo, and looking at the state of my beard, I think I might need to have a bit of a shave before Wednesday. Right, I will see you guys in Birmingham if you are there. Welcome to the new guys. Hopefully that was a useful session for you. If you have any questions about the bones and joints of the knee, we'll do a recap next week anyway. And yeah, if you've got any questions in midweek and just want to clarify some things, pop them in the Facebook group, and I will be glad to help. Cool. If I don't see you on at Therapy Expo, then I will see you next Monday. See you then.